And we are live. Let's see. Yep, YouTube says we are live. So it's already here in Brazil, almost 3 o'clock in the afternoon. Let's grab a MRI scan, an MRI scan from the queue. It's downloaded. I'm going to share my screen so we can report it. This is a, oops. Now I have the microphone. Yes, this is the microphone. I'm sorry. I know nobody was able to hear what I was saying. It's okay. Isn't a major deal. So this is an MRI scan of the lumbar spine. It's a female patient, 63 years of age. And of course, she has some kind of lumbar pain. Let's see here if I can get any kind of clue on the motive. No clinical history whatsoever, of course. It's just guesswork as always. The patient says she has arthrosis and her right leg hurts. This is it. Right leg hurts, arthrosis, lumbar spine. So I'm just going to detach the chat. If someone happens to join us live on the chat, I can readily answer any questions. Of course, why not? It's always on top, and I'm going to look. Yep. So let's grab a template. Oh yes, this patient has all the motives in the world to feel pain in her lumbar spine. This is a T2 sequence. There is no fat saturation because fat is white, bright, and liquor. The spinal fluid is also bright. So this is a T2. This is a T2 with fat saturation, or a STIR stir sequence. It has a inversion recovery pulse, and it just saturates the signal of the adipose tissue, so we can see edematous features easier, because as you guys know, fat has approximately the same brightness as liquid in non-saturated images. And of course, if it's inflamed, it's flooded with liquid, it's pathological, and it's what we are looking for. This is a T1. The fat is bright, but the spinal fluid is dark. So if the spinal fluid is dark, it's a T1, and it's best for morphology. So I also have a axial view. This is a sagittal view, and an axial view, a T2 axial sequence, which is more than enough to see how awful this patient's disease is, how painful these disc protrusions are. So I have 1, 2, 3, and 4 bulging discs. This is an extrusion, another extrusion, and yet another extrusion. I can say with ease that this is not a protrusion but an extrusion, because this axis of the protruded discs is larger than the remaining space between the two vertebral bodies. So this is larger than this. I'm just going to draw a line. This is larger than this. So this is an extrusion. This is also an extrusion. This is obviously an extrusion, and this is obviously an extrusion. So there is a massive, this is a massive case of degenerative disease of the spine, the lumbar spine. So right here, there are some tiny features of bone edema. This is all degenerative right there. Nothing major, but expected. Also, there is some fluid-filled facet joints right there. This is acute. This is synovitis. This is quite painful. There is also edema of the capsular synovial structures of both of these facet joints, and maybe on this one too. This calls for instability. This is probably caused by unstable joints, hypermobility of this section of the lumbar spine. So this is also painful. These are inflamed joints. 1, 2, 3, 4 extrusions. Let's see how much of there is thickening of the yellow ligaments, moderate arthrosis, hypertrophy of the muscles. They are fat infiltrated. Ligaments are thickened. There is reduction in size. There is stenosis, a mild stenosis of the vertebral canal right here on L5S1. Nothing major here, nothing major here, and nothing major here. Let's see the neural foramina. Neural foramina are open, no signs of nerve root compression. And this is it. Mild to moderate arthrosis with synovitis, 4 extruded discs, some degenerative disease on the vertebral bodies and plateaus, thickening of yellow ligaments, stenosis, mild stenosis of L5S1 vertebral canal. So this is quite painful. This is plenty of motive to be in quite some pain. So I'm just going to grab my template. I have a template that is quite like this case, so my life is much easier. Just going to fill up some gaps so we can move on to the next case. And report yet another exam this afternoon. And if you haven't already, just hit that like button and consider subscribing to the channel. I really appreciate it. It helps the channel a lot. We are still looking forward to reaching the 100 subscription mark. We are around 80 subscriptions, and it would be great if you guys could share this video with people you know enjoys diagnostic radiology. Just finishing up. and we're going to be ready to go to the next one in no time. Just bear with me. I have to report it and get it back to the platform, because you know these exams just won't report themselves. They don't report themselves. They still need someone to report them. So it's done. We have one. There is another cervical spine scan. 53 years old, female, and she says, let's see what she said on her file. Just going to load the images so you guys can have a glance. Whoa, whoa. This is painful. Cannot be pain. Cannot not be painful. She says she has neck and chest dorsal pains for about 10 years. I agree. This is a terrible disease, quite painful and almost unbearable without proper treatment. I'm going to just roll the images and point out the disease so we can go to the next exam as fast as possible. So that is facet joint arthrosis, moderate facet joint arthrosis right there. There is unciform arthrosis, moderate right there. This is arthrosis. This is arthrosis. There is a degenerative disease, dehydration of the discs. They have reduced height and signal intensity on this T2 weighted sequence. This is 2, 3, 4, 5, 6, and 7. C7, C2. The atlas is this one right here, the C1 vertebra. So I have at least 1, 2, 3 extruded discs right there. These 2 extruded discs reduce over 50% of the anterior column, anterior spinal fluid column. So I can say with confidence that this is a mild stenosis of these 2 segments. This isn't much. This is just a mild thickening of the posterior longitudinal ligament. Moderate arthrosis right there, and moderate arthrosis right there. Let's see if I have also stenosis of the neural foramina. Nothing much. Neural foramina is right here, and nothing much. The nerve roots are fine. Let's go. Fine. And there is stenosis right there. The nerve roots are compressed out against the hypertrophic facet and oncovertebral joints right there. There is severe stenosis of the 2, 3, 4, 5, 6, 7. The 6, C6, C7 neural foramina. So this is quite painful, and it makes total sense. This is a very severe chronic disease of the cervical spine. And of course we still have a sequence. This is a very bad sequence. There is some bone edema right here. Yes, also some fat deposits right there. This is chronic. This is degenerative disease, osteophytes and all that good stuff that causes a lot of pain. As far as I can tell, there is no lesion of the cervical spine, the cervical medulla. Just degenerative disease of the bone and the discs. I have a template for this as always, so I'm just going to keep my template here and add a few features, a few details about this. Just the vertebral canal stenosis and the vertebral foraminal stenosis. And we should be good to go to the next exam. These are extruded discs, and I have explained this quite a few times already. It's just a matter of comparing the size, the vertical size of the extruded portion of the disc versus the remaining disc space between the vertical bodies. If the disc is larger, the extruded disc is larger, it's an extrusion. If it's smaller or the same size, it's a protrusion. An extruded disc is much worse than a protruded disc. Of course, it's a step forward in the degenerative path of the disease. Just copy and paste the stenosis classification right there, and we are good to go. This is fine. Let's see if we can grab a dorsal MRI scan right there. So we had a lumbar spine and a cervical spine, and now we have a dorsal spine. This is a female patient, also 43 years of age, and she says, of course, she has pain on her back. So she has some kind of back pain, and we are supposed to find out why. Usually dorsal MRI scans are normal, especially on such a young patient, and I'm expecting nothing major of this exam. Morphology of the bodies and the posterior elements of the dorsal spine are fine. This is clearly a Dixon sequence, because the extremities of the sequence suck, are awful. This is a very common artifact when they have a huge FOV just like that and they apply a Dixon technique to run the sequence too fast. So this is blurred and screwed over and filled with artifacts, and it is what it is. It's done. We gotta report it. So discs are fine. Vertebral bodies and posterior elements are fine. Tiny portions of the rib cage, ribs are fine. The spinal medulla is okie dokie, no protrusions, no extrusions, no tumors. I'm just going to roll the axial view so you guys can have fun looking at axial images of the dorsal spine. Right there, medulla, facet joints, costal vertebral or vertebral costal joints right there. conus medullaris, nerve roots, and all that good stuff. So perivertebral muscles are fine, joints are fine, so I can't really tell any motive whatsoever for this patient to be complaining about dorsal pain. It's not on the dorsal spine for sure. So fine, it's done. It has been sent away. Let's grab a brain MRI, right? Why not? A brain MRI is right here. We are downloading it. She also has a arterial cerebral angiogram, MRI angiogram. I'm going to download both so you guys can have fun with me. Let's look for some aneurysms. Why not? Let's see how is the streaming. It says healthy, and it also says we are live for 21 minutes so far. So it's done. Download is done. Let's see this patient. Did she have any contrast enhancement? No contrast enhancement, of course. Why make our lives easier if you can make it harder? So no contrast enhancement. He is 63 years of age and complains of headaches. So MRI scan for headaches. Must be some headache, right? Oh yes, this is terrible. Lots of noise. This is a very low quality exam. I have seen worse. This is an Axel T2. It's shaky. It's filled with noise. Bad. There's usually a very bad head coil. Old coil. Partially ruined. But they still use the equipment as if it was properly functioning. I'm just going to sip my coffee. It's delicious and cold. So they forgot to image the entire posterior fossa, which is just stupid. And he went all the way to the bone on the top of the skull. And I can see there is atherosclerosis, clear signs of atherosclerosis. There is also clear signs of degenerative white matter disease. And on the basal ganglia, this is quite common at her age. There is a bit of reduction in brain size and some degree of enlargement of the ventricular system, at least the supratentorial ventricular system. On T1, pretty much the same. This is a terrible sequence. On flare, yep, just as I guessed. The flare sequence has another inversion recovery pulse that saturates normal fluid. So it's a fluid weighted image, just like a T2, plus another sequence, another pulse that saturates the normal fluid. So normal is black and pathological is bright. So this is much better for anatomy and this is much better for pathology. So I check anatomy here and I confirm pathology in flare. And also acute blood products are bright in flare and are bright also in tissue, so they are kind of obscured by the normal fluid being also bright. So flare is the most important sequence just after the diffusion weighted sequence. So I have mild microvascular disease here of the white matter, both subcortical, deep, and periventricular white matter. And let's see if we have acute stroke, acute ischemic disease. No, this is a very, very bad scanner. This is a ruined scanner for sure, because even they can't even, they did a 5mm diffusion weighted sequence with this much artifacts. So this is a scanner in urgent need of repair. That is a SWI sequence, SWI, which is susceptibility weighted, which means we are looking for blood products and mineral deposits and calcifications, which are kind of mineral deposits. No, nothing of use. Oh, this isn't a SWI, this is in a gradient echo. So which confirms once again this is a very old and badly maintained scanner, because there is no SWI sequence, only an old age gradient echo T2 star sequence. This is a T1 axial sequence, which makes no sense on its own. It's not fat saturated, so it doesn't serve as a pre-contrast phase. This is for studying the hippocampus and the mesial temporal regions of the medial temporal regions. That is slight reduction in size, prominent choroid cisterns, and a bit of dilatation of the temporal horns of the lateral ventricle. So this is MTA grade 2. So I have a template just like this. Let's grab the template and move on to the next exam, which is that angiogram, arterial angiogram I spoke of just before we opened this brain scan. Just add a few features to this report. Oh, sleepy. I'm going to add my template of MTA2, hippocampus classification. Why not? It is what it is. And this is a Fazekas 1 white matter disease, which is mild dilatation, mild hydrocephalus, and we are done with this one. Just going to sign it off and grab a template for the angiogram. This is an arterial, cerebral MRI angiogram for headaches. 63-year-old patient has headaches, so we grab an angiogram. This is mostly noise and very little signal. So this is a very poor quality exam. Nonetheless, we are going to report it because it won't report itself. It has been done. It has been uploaded. And people are expecting a report. So we are going to meet people's expectations. So everyone is happy and we can get paid. And monthly bills also get paid. So this is bottom of the brain, the skull, and this is the top of the skull, as much as the technician wanted to scan. It's okay, fine. This is coronal, this is axial. This is the base of the skull, and this is the base of the skull right there at the foramen magnum. So there is a right-sided dominance of the vertebral arteries. It's a tiny left vertebral artery and a large right vertebral artery, which becomes most of the basilar artery. There is some tortuosity, which is quite normal. She is 63 years of age. It ends up on two posterior cerebral arteries that go backwards and are fine. There is bilateral communicating arteries right there, posterior communicating arteries, fine. And they communicate the posterior circulation with the carotid or anterior circulation. Fine and dandy. Fine and dandy. Internal carotid artery on the right side. Internal carotid artery on the left side. Let's go up through the petrous segments, lacerum segments, cavernosum segments, clinoid, ophthalmic, and communicating segments. So if you guys don't know the segments of the carotid arteries, you gotta know your anatomy. So pause the video and go study vascular anatomy of the brain. It's awesome. Just awesome. The more you study anatomy, the more you are sure you know so little. You should be studying more. So these are the ophthalmic arteries. That is quite common for aneurysms to show up right here. Hello, Chris. Would a non-contrast CT of pelvis and abdomen detect bladder cancer or mass? If it's a huge one, sure, Chris. But usually I do a contrast enhanced CT scan for staging and an MRI of the pelvis for proper diagnosis and local staging. For abdominal infradiaphragmatic staging, CT scan. For local staging and surgery planning, MRI is best. Non-contrast enhancement for neoplastic disease for cancer usually is a bad idea. I wouldn't rely on that. So the middle cerebral arteries are fine, as much as I can see. To M4 segments, M1, M2, M4, and M3 segments are fine on the left and on the right. Let's just look for stenosis. No stenosis. Usually stenosis are carotid. Stenosis on one of those very closed curves. Right there. Nothing major. There might be something right here, almost at the site of the pericallosal artery. Let me just check the sagittal view. My wife had gross hematuria, has since gone away. No other symptoms. CT scan was normal. Well, Chris, if her hematuria, her bloody urine, has gone away, I don't know how old she is, but cancer usually doesn't go away. So it keeps bleeding. So I do a close follow-up, and remember, most causes of urinary bleeding, both macro and macroscopic and microscopic, both gross and microscopic, aren't cancer. They are usually caused by bladder infection, which is one of the most common kinds of infections, especially in young females. So I wouldn't be so afraid of cancer. Bladder cancer is a rather rare cancer. Bladder infection, on the other hand, is really, really common. I'd be concerned of a close follow-up with your physician, a bladder ultrasound with a well-filled bladder done by a good doctor is much better than a non-enhanced CT scan. And you should do some lab workout, lab follow-up to see if this bleeding comes back and if it's of any concern. Oh, don't do that, Chris. If you assume the worst case scenario, you are going to be sick of other stuff like anxiety and panic attacks and all that good stuff. The psychiatrist loves to prescribe very strong drugs too. So it's best to assume good stuff and wait for exams results to come back and have an open discussion with your physician. Having a good physician to talk to is usually better than the exam itself. So the pericallosal artery is fine. Oh, she is 51. Yeah. I wouldn't be worried that much about bladder cancer still. Urinary infection and urinary stones too. Oh, so it's gone. It seems cured. Just be watchful of any recurring symptoms and make friends with your physician. Grab his phone number, and if anything happens, just give him a call and get another urinary exam and maybe an ultrasound if it comes back. So this to me looks like a normal angiogram. Can't really say it could be the motive of persistent headaches. Just going to send it away so we can go to the next one. It's already 21 minutes past 3 o'clock here in Brazil. Let's grab another CT scan of the brain so you guys can have fun. My phone is ringing. Oh, my pleasure, Chris. Hit that like button and I'll see you around. If you subscribe to the channel and share this content with your friends, I'll be more than happy. Thank you so much for joining us in this live stream. So it's downloading. It's a large exam. It's done. Let's load it up. T1. This isn't fun for me. I hope this is fun for you guys, because this is a low field scanner, clearly a low field scanner. Yes, this is very, very bad and usually normal. Oh, he is 16 years old and he has some kind of epileptic seizure. Thank you, Chris. And on sagittal view, this is a T1, this is a T2. Also, they did no fat saturation. This is a regular T2, sagittal, and sagittal T2. Okay, morphologically, I can't really tell much. Hypophysis, the pituitary gland is fine. Let's grab a axial T2. Yes, very bad old age scanner. It is what it is. It has been done. It has been sent to the platform. I have downloaded it, so I have to report it. Cursing at it won't help me much, so let's just smile and report. Smile and report. It seems fine. See, when it's a low quality, low resolution scan just like this, both cortex and white matter look very similar in signal intensity, because it is what it is. There isn't much signal to draw a proper image. It's just usually just make believe. This really isn't a proper exam for much. This is all shaky right there, because since this is a very long sequence, a flare, a T2 plus another pulse signal, the patient has a higher tendency to move. So it's a very long sequence and the patient moves and the sequence becomes all shaky and unusable, because it is what it is. It's a bad scanner. Diffusion weighted sequence, it's really fine. I suppose this has a very low B, so it could be quick. The lower the B, the lower the sensitivity or the sensibility to look for ischemic restricted diffusion signs. So they did the flare once again. Flare is fine. I hope they have done, yep, they did some IR sequence for the hippocampus. And this is a gradient echo for mineral deposits and blood products. It's fine. It's normal. Yes, we have an IR, T2 IR sequence for the hippocampus. This is great for morphology. Looking for mesial temporal sclerosis. Oi, eu tô fazendo uma live. O que tu quer? Tu quer meu celular? Tá. Yep, this is home office. This is how it goes. So this is an IR sequence. This is for morphology of the hippocampus in the mesial temporal region. Also, we can look for heterotopic sites of cortex matter, of gray matter. Nothing major, nothing that could be pathological as far as I can tell. It's odd how they spend so much time on such sequence and so little time on the proper T2 and T1. So this is flare, coronal flare, oriented for the hippocampus. The hippocampus is right here, and it's oriented properly from the amygdalar body to the tail of the hippocampus, and there is no asymmetry of signal intensity. So this is a normal brain MRI scan of a 16-year-old male patient that has some kind of primary epilepsy. Maybe it's just a first time epilepsy with no organic cause, which is quite normal. I would be happier with this case if they had done it with contrast enhancement, because you guys know sometimes contrast enhancement in such cases is of utmost importance to see tiny lesions that could be related to secondary epilepsy. But it is what it is. We are done here. Let's go. I'm going to see how long are we online. We are already at the 48-minute mark. Maybe we can report yet another scan. Let's see what I have here. I have right there, this is fun. I have a internal auditory canal or temporal bone scan. I'm pretty sure you guys don't go across these kinds of scans every day. It says this patient, a male patient, 59 years of age, has asymmetric hearing loss. Asymmetric hearing loss. He has a previous exam of about 10 months ago, and the previous exam was normal. Maybe it's not. So this is a sagittal view. A sagittal view that makes no sense in this case because we are not looking for brain lesions. We are looking for lesions of the internal auditory canals. A flare, thick and useless, diffusion weighted sequence improperly done. This is very bad. We have a balance SPGR T2 weighted sequence right here. I don't know how they call this in this particular scanner. It's just a proper heavy weighted T2 volumetric axial acquisition, so we can see the morphology of the internal elements of the temporal bone, the neural ear, modulus is fine, semicircular canals, the cochlea, the sacculus, and the 7th and the 8th cranial pairs. Fine. Fine right here too. Let's see. There is no deformity of the interior structures of the ears. No disturbance of the proper low signal of the mastoids and the middle ear, and the external ear canals are fine. This is a T1 non-enhanced, T1 right there, left and right, seems fine. Let's see some enhancement. Do we have enhancement? Yes, we do. But they made a very common mistake. They made a pre-contrast without fat saturation and a post-contrast with fat saturation. I can't compare this sequence to this sequence because these are different. This isn't the same weighting as this, so it's impossible to properly compare these images. If you want to do a comparison between pre and post enhancement phases, you have to do the exact same sequence, including the saturation of the fat signal intensity. So fat signal is saturated here, and there is contrast enhancement, but in this case I have no signs, as much as I can tell, of anomalous enhancement of any portion of the inner ears. No justification, no motive for hearing loss, symmetrical nor asymmetrical in this case. They also did a coronal post-contrast phase, which makes no sense, just to waste more time. And we have a normal scan, just as in past December. I'm just going to grab my template. I have a template for this, of course. And I'll be on my way. And we are done with this crappy scan. Crappy scan. Oh, let's I don't know, a lumbar spine, just for fun. Lumbar spine, This patient is a female patient. She is 43 and she has lumbar pain, lower back pain that goes all the way to her inferior right limb. So she has a classic right-sided lumbar pain. Let's see if we can make any assumptions based on the images that could be related to her complaints. It's downloaded, it's done. Here we have a T2, a regular T2, no fat saturation, fat is bright as much as the spinal fluid. See, the spinal fluid is a bit brighter than the fat, which tells us the weighting is perfect. This sequence has perfect parameters. So this is fine. The bones are just slightly brighter than the muscles, which tell us they are fine, and the image weighting, the image acquisition is correct. And as we go for the fat saturated sequence, the fat is homogeneously saturated and we can readily tell the cause of her pain. Can you tell the cause of her pain? It's not easy, but it's quite apparent. I'm going to roll the axial T2 and I'm going to roll over the motive for her painful complaints right there and right there. It's quite painful, but it isn't related to disc herniations. No protruded discs, not as much as those cases we saw earlier, although we have here something right here. What is, yep, what is that? This is left side. She says her right side is in pain, but we have a tiny ruptured disc. This is a annulus fibrosum rupture. The fibrous ring of the disc has a concentric rupture right there. This is painful on itself, but it's quite far from the nerve roots right there, so it shouldn't be a problem, at least not a direct problem. There is another rupture right there, right there. Yep. This is very tiny. A tiny protrusion. I can't really tell it's a proper protrusion because it's so tiny, so I'm going to ignore it. And also hypertrophy and fat. Oi, senhora. Tô.
Só me olhe esse exame que eu fui receber.
Eu olho já falo com a senhora, tá? Quando eu terminar aqui. So there is fat infiltration and hypertrophy of the perivertebral muscles, and there is arthrosis and some fluid in the facet joints of L3, L4 and L4, L5, which is hypermobility or synovitis, and is painful by themselves. So we can readily tell this is a painful spine. There is some signs of very mild edema of the interspinal ligament of L5S1 right there. This is also painful, so let's do it. Let's do it. Let's report this. I have a template quite like this. Just going to add the annulus fibrosum ruptures. Yes, no protrusions, but I have degenerative disease and synovitis. L4, L5, and L3, L4. Also, mild edema of the interspinal ligament. Right there. And hypertrophy of the perivertebral muscles. Hypertrophy. Perivertebral muscles. Right there. Synovitis. And hypertrophy. Yes, and we are done here. Yet another scan properly reported. So guys, we have already passed the 1 hour mark. Thank you so much for being here, for watching this video, and consider subscribing to the channel. Hit that like button, leave a comment on the comments below. It helps a lot. YouTube will offer you and other people more videos that I publish here, and of course I'm trying to be as frequent as I can with these live streams. I'm doing about 2 to 3 live streams a week. Maybe I can do daily live streams. If you guys want, just leave in the comments below. I have fun. I hope you guys have fun. And this is it. I'll see you guys in the next one. Thank you so much.